Well, hello and welcome to our January Lunch and Learn. My name is Brian Lorch. I'm the Director of the Interprofessional Education Office at Grand Valley State University. The Lunch and Learn series is offered during the academic year from September to April, sponsored by the Grand Valley State University Office of the Vice Provost for Health and the Midwest Interprofessional Practice Education and Research Center. These free events are open to students, faculty, staff, MIPERC partners, and community members. The series features speakers who are demonstrating interprofessional education and collaborative healthcare practices in unique settings. Each session features a timely topic related to healthcare practice and delivery. And today's topic related to telehealth and telemedicine is certainly very timely. Before we begin, I'd like to introduce our speaker for today's presentation. At Mass General Brigham Partners Healthcare, Dr. Kvedar has focused on driving innovation, creating the market, and gaining accepted for connected health for nearly 3 decades. He is now applying his expertise, insights, and influence to advancing adoption of telehealth and virtual care technologies at the national level. Dr. Kvedar continues to guide the transformation of healthcare delivery as a respected thought leader, author, and convener. Dr. Kvedar is president of the American Telemedicine Association and served as program chair of the ATA 2020 annual conference. As editor-in-chief of NPJ Digital Medicine, a Nature research journal, he is working to establish the evidence base needed to guide innovation and the implementation of digital health. He is co-chair of the American Medicine Association's Digital Payment Advisory Group, works to ensure widespread coverage of telehealth and remote patient monitoring, and successfully established several new provider codes for telehealth reimbursement through the CPT process. Dr. Kvedar is also a member of the AAMC's Telehealth Committee, creating tools that will enable medical schools and residency programs to integrate telehealth into the training of future practitioners. Dr. Kvedar is the author of 2 books, The Internet of Healthy Things and The New Mobile Age, How Technology Will Extend the Health Span and Optimize the Lifespan. I'll include links to his blog and some other access links in the chat. And Dr. Kvedar is a professor of dermatology at Harvard Medical School. So with that, I would like to turn it over to our speaker for today's presentation.
Thanks so much, Brian, and thank you for inviting me to talk to this group about this very exciting topic. As you say, it's a very timely opportunity as well. And the title that I've chosen is The Ideal Integration of Telehealth into the New Normal. Sadly, we're not past the pandemic yet. I understand that. But really what it did was it provided us a very quick evolution for telehealth from what I would call prior to just about a year ago was more of a curiosity for many people, a proof of concept, something that folks dabbled in. Your perhaps more advanced from a technology perspective, healthcare systems were doing more of it. Some people had a real financial reason, if like a Kaiser Permanente, where they're fully at risk. But most of the time, and we had some data from, for instance, the American Medical Association survey and others, that maybe 16% of doctors did something. And then, of course, the pandemic hit, and I'll go over some of that in more detail. And we went from sort of a research question to implementation almost overnight. Now, for those of us who are advocates, that we were quite happy to see the rest of the world pay attention to this mode of care delivery. That said, I'm not sure it served us well, and again, I'll walk through what I mean by that, simply because people got the idea that it was like a switch. Now we turned on telehealth, let's go. And of course, anytime you implement anything new, you run into snags, and many of the snags were not, thankfully, clinical. The outcomes were good, but it was more operational, integration into workflows, choosing the right patients. And again, these are all things that I want to cover. So now we find ourselves at the first days of 2021. The Biden administration is already, I can tell you, very telehealth friendly. So we see a bright future for the integration of telehealth into care delivery, but there's still many questions unanswered, which I want to lay out for you and then leave plenty of time for us to have a dialogue around the topic. These are disclosures, which of course for any continuing medical education series. I'm obligated to share them. I will say that none of them are particularly relevant to the content I'm going to share with you today. And our objectives for today, well, learn how telehealth is being used during the public health emergency, how that's influencing adoption, including resources for both patients and providers to better understand best practices in engaging with a patient during a virtual visit, and to understand which scenarios are best suited for telehealth and which perhaps are better suited for some in-office care. So to really start and to really step back for a minute, because I've been at this now for almost 30 years, and it wasn't because I was like Nostradamus and envisioned a pandemic coming in the year 2020. It was because I really felt like this was an important step forward in the delivery of care. And this chart really illustrates why. What it shows is the demand for healthcare services growing much faster than the supply of providers. And I say that, but it is with one very important caveat, and that is the only way that we provide service is face-to-face or one-on-one. And as much as virtual care has opened up new vistas for us, and really many more clinicians are involved now, many more patients know what we're talking about, most of what was done over the last year was also one-to-one virtually. And that doesn't really help us solve this problem. We've got to move to something we call one-to-many. Now, other services that you consume have done this. For instance, when you go to a Target or a CVS or any other retail outlet these days, you'll notice that there's a section where you can self-checkout. There's probably 8 or 10 checkout stations and one individual who will serve you if you need. If you can't sort it out yourself, that individual's there for you. And you usually scan your SKUs, your card, and you're out the door. So 1 to 6 in that case. But in healthcare, it's more like 6 people that you see when you check in before you get to your doctor. So we're kind of in the opposite direction on this. And telehealth is one way to get there. Now, again, most of what we're going to talk about today is virtual visits, because that's been the very hot topic for the last 10 months or so. But we have to start moving, and I will have a little bit on this when I talk about remote monitoring at the end. This idea of doing one-to-many, and that we mustn't lose sight of that, because as I said, if we don't, we're simply going to outstrip, and already have outstripped, our supply of providers. So I want to start the discussion by some terminology so that we can all be comfortable with some of the words that we are going to use. And this chart was created by colleagues of mine at the Massachusetts General Hospital Center for Telehealth. It's not my original work, but I have adopted it, and I find it very useful. And it breaks telehealth into 4 categories. The columns being about whether it's real time, i.e. the way we're interacting right now, or like a phone call or like a video call, real time. And the other column being asynchronous, store and forward. What that means is more like an email or a text message exchange. Not that those, of course, are secure enough for telehealth, but conceptually, like you message something and I, as a recipient, will get to it when I get to it. It gets more efficient for me to do that. That's asynchronous. So that's what the columns mean. The rows are about whether it's provider to patient, and if so, we call it a visit. And or if it's between providers, say one specialist helping a primary care doctor with a patient, that we call a consult. And you'll see that sets us up for 4 grids. So something like a e-consult would be, I'm a dermatologist by training, a primary care doctor sends me a few images of a patient and a little bit of history, and I respond and say, gee, it looks to me like psoriasis, here are some things you could try. That would be an e-consult. a virtual visit, which again has been the hot topic for the last 10 months, is a video call between a provider and a patient in real time. And so you get the sense of how these terms work. Gotta find my forward button again. There we go. So of course, the other thing that I like to mention when I'm talking about telehealth in the year 2020 is that we did not start from scratch. No, in fact, things were happening in the background. And if you have looked at, for instance, the Everett Rogers adoption curves, you know, for classically for things where people communicate, you go on this sort of gradual increase till you get to about 20%, and then it flips and goes more like a hockey stick. And so we were arguably heading towards that hockey stick before this pandemic. The pandemic was the forcing function that got us there, but consumers were definitely more comfortable with technology. When I started doing this, you had to buy a big $60,000 TV set with a codec in it. You had to string 3 special telephone lines called ISDN. People just weren't doing that for obvious reasons. Now you get it, both the network, the video, all of it in your mobile device. It's easy. Everyone FaceTimes with their children. Everyone Skypes with their friends overseas. And most people are very comfortable with that. One of the other things that Brian mentions, I'm co-chair of the AMA's Committee on Reimbursement. And indeed, over the last 4 years, we have populated the CPT book with codes for virtually all, no pun intended, all kinds of telehealth activities. So the reimbursement infrastructure was ready. It is a good fit for volume to value. We won't probably talk too much about that this afternoon, but it's people were experimenting. And as I said, an organization like Kaiser has gone very, very deep into this activity. And of course, we had digital natives, both as patients and as providers, people who I used to joke had grown up breaking up with boyfriends and girlfriends by text message. So why in the world couldn't we do text messages with our patients? So this foment was there. And then all of a sudden, here we go. It's time for the pandemic. And none of this really is particularly news at this point. So I'll go through it very quickly. But the forcing function was lockdown. You have to stay at home. We have to take care of you. We're going to migrate very quickly to telehealth. Now, it's interesting, but 9 or 10 months later now, our governor just asked us to start redoing this, not nearly in the same way. We're still having patients come into our offices, but we're offering more and more telehealth to our patients because we want to make sure that we bend the curve here in Massachusetts, as I'm sure you do in Michigan as well. So this forced new workflows for patients and providers. People, again, had to get really involved very quickly with this whole notion of telehealth. And there were 3 relaxed types of regulatory restraint, which again, by now you all know, I'm sure. One being reimbursement. During the public health emergency, payers are required to pay for telehealth technology, or HIPAA, meaning the government said they would not enforce HIPAA requirements for the technology, meaning you could use Skype, you could use FaceTime with your patient. I think at this point, most people have adopted a HIPAA secured telehealth platform. And there are a couple of them that even individual practices can use, like Doximity Dialer or Doxy.me. So that's, I think, a little bit less relevant. And then finally, licensing. 49 out of 50 states now will allow a clinician to care for their patients in their state from another state due to telehealth in the public health emergency and COVID. So all of a sudden, we were off to the races. And this is just one example of what that looks like from a primary care practice at the Beth Israel Deaconess in Boston. And you can see the blue lines are in-person visits, and the green lines are volume of telehealth visits. And again, it flipped like a switch in the middle of March. And it's come back down now. Most people I've talked to are are reporting anywhere from 10 to 20% of their ambulatory activity is telehealth. That seems to be a comfortable area, and it's going to vary by specialty, which I will illustrate for you here momentarily. So as I say, maybe 30% in May. This is April and May data, but it sort of came up to that and then kind of back down just a little bit over the summer. Second surge now, people are trying to do more. And again, on the one hand, I'm really pleased to see people adopting telehealth. I do think the big Achilles heel in this whole thing is if people get the sense that it's a pandemic solution and not a mainstream healthcare solution, we're going to have some, I think, challenges. We're already seeing payers start to push back a little bit. Now in Massachusetts, we've just passed, our state legislature passed the bill, which requires payers to pay. So things are moving in the right direction. Certainly Medicare is very bullish, and I have a slide on that as well. So I think we're going in the right direction, but we have a little bit of tidying up to do as well. And these are just, again, some examples from health systems and some of the supplier companies from March to June 2020. And it's all this enormous amount of increase. As I said, the most remarkable thing to me about this is that we did all this without really, I'm not aware of any untoward patient consequences. So I don't think you can say we all got lucky. I think you've got a lot of diligent professionals doing their best, and that we perhaps don't give our clinicians enough credit for the intuitiveness of making decisions around diagnosis and treatment with the technology at hand. So it's now a household word. That's the bottom line. I haven't been to a cocktail party in a year, but when we go back to cocktail parties, I will not have to explain to people when I say I do telehealth, what that means. And I used to do it all the time. It's like a 10-minute conversation before we even got to the point. That's done now. And every pretty much doctor and every patient around the country knows what this is. And that's got to be a big boost for the industry. And we've successfully brought the doctor's office into the home. And yes, again, I don't want to take anything away from that because that was a big move for us. But it's also somewhat limiting when you consider all the things that we can do with digital in healthcare delivery. It's a start, and I think we have to look at it that way, and we can't be sort of saying, okay, well, we figured telehealth out now, what's next? So we still have a long way to go to fully integrate digital into the care delivery process. So as promised, this is a few thoughts on how, when you're caring for a patient and you're preparing them for a telehealth visit, what's different? Well, one of the things that I think annoys everyone and makes everyone feel a little bit down in the mouth is when you go through, because it is typically to get patients on a video call because we're using either a channel through the electronic record or sometimes an app that they're not familiar with. There's a bit of work, right? Let's face it. And sometimes it's like more than one try. And then if you get on the call and they don't have something you need, that's pretty upsetting for everyone. So make sure they know what you need. If you're needing lab tests done, make sure they get done. If you need x-rays done, let's make sure they get done. Other things that you will need to care for them. People can do a lot of physical exam maneuvers on themselves and report to you, but you have to prepare them ahead of time. All video technologies now come with a waiting room, and you use that room thoughtfully. You might have some instructions in the waiting room to almost similar to the slide that was up when you all joined today, where Brian had a slide up that sort of gave some orientation. You should think about how you use your waiting room. Now, here's one. People that are doing this when they're doing their telehealth, because They don't realize that the camera is where it is, and they think they're looking at the patient in the eye. You have to train yourself to look at the camera. It's an uncomfortable feeling at first because you want to be looking at the screen where the patient is. You have to train yourself to look at the little green dot. And if you do that, then the patient will feel like you're looking them in the eye. Very important. It's sad that I have to put dress and groom appropriately, but it's a fact that we've seen some a little bit more wacky dress code for virtual care than I think would be acceptable in person. And that's just not right. It's care. You have to be professional. You have to look professional for your patient. Sometimes we need consent for various things, and you want to make sure you do that. If they have a choice, meaning they could come in the office or they could do it virtually, make sure you let them know that. Don't emphasize either mode unless you feel like there's a very clear reason that something should be done a certain way. And just help them give you information in real time. So those are some things about virtual care that are a little different than in person. So what are the right use cases? Well, they're shaping up to be more and more. And the reason for that is as we get more and more adjuncts to the virtual care experience, and I'll explain that a bit. You get more and more data points. When you get more data points about a person, there's more you can do. So what I like to ask clinicians to think about this, because again, inevitably people come to it with bias, is they say, what information do you need to make a diagnostic or care plan decision? And if you don't need to touch the patient to get there, then you're good for telehealth. And we've had cardiologists will get an echocardiogram, see that, and then see the patient virtually. Whereas, curiously, they used to bring you in the office and listen to your heart. In this context, maybe the heart exam by the stethoscope isn't as important. That might be blasphemy to some people, but seems to be that a lot of specialists are really thinking through what they need. And if you don't need to touch the patient, then telehealth is a good option for you. Behavioral health, mental health is top of the list. As I said, I have a slide. I'm going to show you a little bit more about that in a moment. And then virtual urgent care is a big bucket. And you can see the various indications for that. Usually it's a limited set of symptoms. Usually these used to get to it through your health plan, where you go to a website, sign up, do a authentication process, tell them what your challenges, and then you'd video conference shortly with a clinician, usually in the beginning, a psychologist in that case. But more often than not, more and more. And now more and more psychiatry is being done this way because why? Well, the physical exam is talking to the patient, so it completely makes sense. So virtual urgent care, and then follow up for chronic conditions. People that you know and that are fairly focused, whether it's a blood pressure check or someone with diabetes. Now, this presupposes they have the equipment at home, like a blood pressure cuff, or they're doing their blood glucose readings at home so that you can incorporate those data into your discussion with them. And so what not to do? Well, I think the complete annual checkup is better done in the office. I've had a lot of patients tell me that their primary care doctor did their annual checkup by telehealth. So I'm not a primary care doc, so maybe I'm wrong. I don't know. Perhaps we can talk about it. But I think something that thorough, and complicated should be done in the office, but that's just me. I think instances where you need certain other data, and as I said earlier, those can be done virtually, but the really difficult thing from all perspectives is to get the person on the line and say, all right, well, I need CBC and I need a urine culture, whatever it is, to help you. If you could have got those things up front, it would have gone much more smoothly. I think that patients with multiple chronic conditions, and as these are all relative except for the last one. I often say that the desire for telehealth is directly proportional to how many miles the patient has to drive to see you. So for some of these things, we might stretch it a little bit, meaning we might do telehealth. Again, you're never going to do poor quality, but you might push to do something that's a little more convenient for the patient. And I think a highly sensitive matter like a new cancer diagnosis, again, this is just me, but I think that's easier to look someone in the eye across the table and talk to them about that than do so by video or phone. Maybe, again, maybe I'm off. Finally, anything procedural, obviously, but I mention it because so many specialties, dermatology is one, ENT is another one, others, where you sort of are melding the medical and the procedural, and using telehealth requires you to tease them apart again. So that's certainly important to think about. This is a slide I was referring to earlier when I say what is the right mix. So what this slide shows, if you if you want to not pay too much attention to this, this comes from the Commonwealth Fund. I'll explain it to you. It is the percentage of, pardon me, visits lost during the lockdown phase by specialty, which again tells you approximately how telehealth friendly these specialties are. So really the longer the bar, the more the work has to be done in the office. So number one is ophthalmology. That's why I chose this picture. Lots of machines. You got to stick your chin in various things. You kind of can't do that without going to an office. All the way down to behavioral health, which I mentioned earlier, where up to only 30% of volume got lost. So that means up to 70% easily done via telehealth. And again, that makes sense. And you have everything in between. All right. So that's the current state. We're at this point where we're entering what I call a hybrid phase, where people have done all telehealth all day long, then they pulled back, they integrated it with, and various things emerge because, as I said, it's no longer about an experiment or a proof of concept. It's about, okay, how do we integrate this into what we're doing? So number one, this is a very positive quote from I believe she's still the CMS administrator. I don't think she's been replaced in the new administration yet. Her name is Seema Verma, and she's on the record as saying this multiple times in the last few months. I think the genie's out of the bottle on this one. Safe to say the advent of telehealth has just completely accelerated, and it's not going back. As I said, this was quoted in late March. She has been continued to be an advocate. She's made sure that Medicare pays us. And as we brought patients back into the office, we've seen a slight drop in telehealth, which makes sense, finding our equilibrium. So for the most part, reimbursement's on our side. Now, as I said earlier, the payers are starting to do some squirrely things as they see the light at the end of the tunnel. So I think whatever policy people you have in your organization, I would urge them to get involved. ATA is doing a lot of work in this area, AMA is as well. You can do your own too, but I always feel like there's strength in great numbers when people approach government as a united force. So get your government affairs people focused on what we call cement the gains, and that is get whatever regulatory relaxation you picked up. Let's make sure that we don't lose it as we get more and more people that are well. So what trends are there to watch? Well, we've talked some about this. So I mentioned the regulatory equilibrium of these three things, reimbursement starting to get sorted out. Big houses like United Healthcare and Aetna already reimbursed for this. So we're headed in the right direction on that. The technology I mentioned earlier with the more and more people adopting HIPAA compliant technology that integrates directly into their electronic record, and then licensure, which I mentioned earlier. Now, The next section is about things that I think in the next few years we're going to see more and more of, because as we've learned, as I said, we brought the doctor's office into your living room. All of a sudden people are saying, well, if I had X, then I could add to that list of use cases that I showed earlier, because with X, we could do everything virtual. And they usually fall into these three buckets. So digital biomarkers is a fascinating concept, but it's software that lives on your mobile device that can track something about you um, and use it as a biomarker for your disease. The commonest one is, oh, sorry. The commonest one of these is um, for mental health, for checking to see if people that, for instance, with your vocal tone, whether you're depressed, those kinds of things. And there are multiple of them. Home devices are coming on the market. You'll see more and more of those. The one that I like to talk about is by a firm called Tyto. It's called a Tyto Care, and it can look in your ear, it can look in your mouth, it can take your heart rate. And again, it's interesting that you have this kind of thing, which all of a sudden makes the virtual visit so much more effective. So how do we get one of those in every medicine cabinet? I'm not sure, but that you'll start to see that kind of thing happening. And then finally, home lab testing. All the home lab testing firms are really focused now on pretty much on COVID testing, and I guess that's a good thing. But you'll start to see more and more lab testing kits, notwithstanding the debacle that Theranos put us through. You'll start to see more and more home testing kits for things that are relevant that you can do for your chronic illness management that allow your doctor to take care of you virtually. We talked a little bit earlier when we were doing the grid about asynchronous. I haven't spent much time on that, but let's pretty much agree that it's more efficient. We have codes for things like e-visits, which are essentially a text exchange with your doctor over your patient portal. We have codes for internet interprofessional consultation, which is a text exchange between doctors. So you'll see more and more of that, because that's really the next phase. And then remote monitoring, which I'm going to talk about here momentarily. What are the business implications of these changes? Well, I think the most interesting for providers is what it's all about the overhead and the use of the physical plant. It's a new era. I do my telehealth sessions on Tuesday afternoons now, and I do them from my home. I don't need to come into a physical location. I have a clinic tomorrow with Nantucket Cottage Hospital where I'm beaming in from my home office. These things are starting to become much more commonplace. That's a different overhead structure than if I went into the hospital to see patients like I did this morning. So we have to rethink that. We have to rethink what we do with that fixed asset, and how we do overhead calculations as we grow. And there are workforce implications as well, because you'll have these already. You're seeing this in the vanguard, but people who are, I call them the Uber drivers of healthcare, where they sign up for multiple telehealth services and they put their hours in, and they make a living by doing a few hours today, a few hours tomorrow. And they're never really in the office with patients. There are doctors like that, and you'll see more and more of that. Payers are worried. I've alluded to this before. Is telehealth additive or substitutive? That's a big worry. A quick example, I saw a patient recently with a changing lesion on the forearm by telehealth, sent me an image. We had a phone conversation. I said, yes, that should be seen in the office. Patient came in the office the next day and we did the biopsy. Now, as I billed for that, I billed for the evaluation and management code on the telehealth and just the biopsy in the office. But most clinicians aren't going to be that thoughtful, and they will find a way to double bill for evaluation and management. Not because they're dishonest, not because they're greedy, but just that's the way we're trained. We're trained to maximize our billing opportunities. So we have to rethink that. And payers are going to be all over us if we don't. So that's something we have to take the lead on. And again, payers are really worried about opening the access floodgates and creating more and more cost. And whether that's true or not, whether that's a false concern, as the provider side of the equation, we have to embrace the conversation and work with them to try to find a way that we can all do this together. It's too important to fight over. So telehealth is here to stay. These are conversations that clinicians should be having. Do I intersperse my schedule? Again, if you can bundle it and do it as a separate session in your calendar, it's more efficient. So hopefully that's what others think. I think interspersing it between patient visits is both higher use of overhead that's unnecessary and less efficient, but we'll see how that all plays out. Do I need a special software platform? Well, yes, you do. If you're in a big system, your IT department will have sorted that out for you. But if you're a practitioner in a small practice, you need to make some decisions. Happily, as I said earlier, Doximity and Doxy, doxy.me, are both platforms that are either cheap or free that you can use that are HIPAA compliant. So we'll see more and more of those. And I don't know if we'll ever do clinic to clinic. It used to be that you could only bill Medicare if you were in a clinic as a provider and the patient came to a clinic. As I mentioned, I do with Nantucket Cottage Hospital. Nowadays, during the public health emergency, all that's gone away. As I said, I'm doing my Nantucket clinic tomorrow from my home, perfectly legitimate. And I don't know if we'll ever do clinic to clinic again. So that's the bulk of it. We've successfully brought the doctor's office into the home, but if we really stop there, it's an incredibly limited view of what we can and should do with digital technology. It's a little bit like, I use the analogy that when Alcoa first invented aluminum, I think it was the 1920s, 1930s, they didn't know what to do with this new material, this strong new material. So they would do things like create a coat rack made out of aluminum and paint it to look like wood because people were familiar with wood. That's what we don't want to do with telehealth. We don't want to try to shoehorn it into a workflow that works in the office. We don't want to do video only. We have to really rethink how we use these tools. And so many other industries now are digital first. Some of the other industries are communicating with you and working with you through mobile, through digital, through AI, et cetera. That's where we have to get in healthcare. So this, frankly, is just the beginning. It's really our opportunity to reimagine healthcare delivery. So remember now the ratio of patient to provider, and I want to just reinforce that because that's important. That's the reason we're all doing this. If we don't get that right, we'll continue to flounder. Now, remote patient monitoring, I'm going to just say a few words about it because, as I said earlier, when we start to look at the trends of the next few months to years, this is going to emerge. It's an obvious thing. By the way, that's something else we worked on in the coding group that I'm involved with the AMA. So we now have very robust codes for remote patient monitoring for you to use them to help manage your patients with chronic illness. This is an example of what you can do. This is heart failure telemonitoring. You see the cartoon of the technology. Patients take home a weight scale, blood pressure cuff. Usually the tablet that you use is traditional. Often it's an Android tablet. It's not special, but it's connected to manage these devices and send their readings over the cloud, over the internet to the cloud where a provider can harness them. And this data is from a study we did some years ago showing that for both all-cause readmissions, the top blue line, and heart failure related readmissions, the orange line, over a year period, there was a significant 50% drop in both. And we measured readmissions because at the time we were focused on readmission penalties and we were focused on value-based care arrangements. As I said, telehealth's quite good for that. Nowadays, you could redo this graph just looking at the revenue that you could bring into your practice by managing chronic illness this way. depending on how many patients you have with heart failure, diabetes, hypertension, that you can monitor. Most practices say there's $250,000 that they could bring in using this remote monitoring tool set. And happily, there are many, many vendors who will happily put the service in for you, help you with the billing, and you just have to provide them and their nurses with a input around prescription management and things like that. So this will grow for sure. The other way you can look at the other use case that I like is both hypertension and diabetes. You can see some of the data from our programs, and this woman's taking her blood pressure. So patients that are new to use insulin, it's a great use case in diabetes. They're onboarding, they need to manage their sugars carefully. Or patients with either difficult to control hypertension or newly diagnosed. As probably many of you know, the state of the art now for newly diagnosed hypertension is to measure your blood pressure in the home for a couple of weeks before you go on medication. There are codes to reimburse for that. No reason why that couldn't be done electronically as well, and make it easier for the clinician to help you make those decisions about your medication titration, and even do that virtually as well. So it's, as I say, our opportunity to reimagine healthcare delivery. And I'm just going to quickly go through. I already talked a little bit about some of these home testing, home devices, very important as well because of what I said, which is the idea that we're going to be able to add data to the patient visit in a timely way that enables the clinician to make more decisions. Remember, I said if you can make your decision without touching the patient, well, we need data to make those decisions, and home testing, home devices help us gather those data, as well as with digital biomarkers. So I mentioned the mental health version. The other version I like is, and there are a number of these now, where you can cough and software on the device will analyze the cough and is able to tell the doctor whether you have asthma, pneumonia, bronchitis, what have you. In other words, diagnose your respiratory illness based on the sound of cough. So you see lots and lots of these digital biomarkers coming out. There's software downloads. They take advantage mostly of local training and local tone that you and I don't even notice, but we can train software to recognize if you're depressed or, for instance, diagnosed with your cough. I mentioned asynchronous telehealth a bit. Chatbots are really interesting symptom checkers. We didn't talk much about that. I'll just quickly mention those. The idea that integrating artificial intelligence on the front end, again, every other service delivery is doing this now. Anytime you go on a tech support website for anything from Best Buy to Verizon to AT&T to anybody, you get a robot first. Apple does it. Now, the smart ones have figured out, and I think this is the harbinger for what we need to do in healthcare. The smart ones have figured out when and how to quickly get you to a human being so you don't get frustrated with a robot. That's very important. We can't do digital first in healthcare if people feel like they're being denied care by a human being. That will never work. But you'll see that coming. There's several companies already doing an interesting job in terms of integrating these symptom checkers and chatbots into the care process. These are some resources for you, and I think Brian will have these slides, and I believe the hyperlinks are still active. Now, the virtual annual meeting of ATA, that's a link from last year, but there will be one in the spring. There's a AMA telehealth practice guide. We have a nice Nature article on systems approach and a patient's guide to telehealth. So those are all some resources that you can review if you choose to. And these are my contact information if people want to contact me offline. And I'm now going to stop the share and happy to turn it over to Brian to manage the Q&A. Thank you.
Well, yeah, thank you again, Dr. Kvedar, for that excellent and incredibly informative presentation. We have a number of questions in our Q&A, so I'll jump right in with some of those, and maybe some will piggyback off each other. So I'll start with the first one, which is, in the past, doctors used to make house calls when an individual was sick. Do you think telehealth is perhaps removing that personal connection individuals had with their provider? And if so, do you think that connection is important, or what might telehealth do to keep that kind of more intimate connection?
It's a wonderful question. I'll try to be succinct. People often call virtual visits the house call of 2020. So I don't think if the provider is well trained and sincere, what we find is that the connection can be made. We have something we call website manner, actually. And one of the things I'm doing with that AAMC that you mentioned is getting that teaching into the curriculum of medical students and residents. Not every, as I said, if I had a newly diagnosed cancer, I probably want to sit across the table from my doctor to talk about that. So not everything, but a lot we can do. And it's especially valuable for patients that you already know. If you already have a relationship and you're doing something that's more or less perfunctory, like a blood pressure management change or something like that, then I think it works quite well. For brand new patients or for complicated emotional issues, yeah, maybe you should come in the office for those if you can.
Thank you. One of the things you mentioned in your answer related to training, and we have a question that asks, how do you think graduate programs such as MD or DO or NP/PA can better prepare future healthcare professionals in implementing telehealth in their practice?
Yeah, thank you for that. And so again, I'm going to call attention to the AAMC. I should have put that in that slide of resources. But if you go to AAMC.org, I think you can find a link to a set of competencies that we just released, which are intended to do that. So having released them now, it's a little bit like putting your name in the phone book, right? Well, we have to go out and market them. And indeed, the AAMC is doing that to their constituents, which are largely academic medical centers with training programs. So our hope is that these competencies will get embedded into the care training of our medical students and residents within the next year or two.
Thank you. Are there any worries with misdiagnosis?
Sure, there are. Of course, there are. But there are in the office too. And as I said, clinical judgment is about the data you need to make a decision. So what I tell clinicians is, if you can, once again, make those decisions without touching the patient, you should be able to do it by telehealth. My colleagues in dermatology will say things like, well, the patient came in for a bump on their arm, but I found a melanoma on their back. And sure, that's true, that can happen. And you could be the unfortunate doctor who missed that melanoma on telehealth. On the other hand, if you're clear with a patient and say, we're dealing with your forearm today, this is not a substitute for a full body exam. Just have that dialogue so they know that what their side of the bargain is. I think it can be managed. So I would say there's no more chance, if you're thoughtful in how you approach the gathering of information, there's no more chance for misdiagnosis in this medium than in person.
Thank you. Another individual asks, I have heard that compliance rates have improved among individuals with mental health illness, and I think there was a slide that demonstrated that. However, are these patients enjoying telehealth, or are they reporting a preference for in-office visits?
It's a good question. I don't know. I don't know exact data. I will tell you anecdotally what I'm hearing. And if you think about behavioral health, and not all behavioral health, but it's a lot of it's about stress management. So I'm in a town like Boston or New York. I have to leave my home, take public transportation during a pandemic, sit in a waiting room, go into another room. By the time I get in front of the prescribing doctor, I'm not myself. My mental condition is at its worst. So it feels like patients can do better by not having the stress of leaving their home. Interestingly enough, doctors seem to get more information because they see what we call the patient in situ, what's around them, what their family's like, and that helps them understand the behavioral illness a little bit better too. So we think for behavioral health, it's maybe even better than face-to-face. And I think that accounts for some of the very, very robust adoption in that field.
Great, thank you. How about thoughts on team-based care or interprofessional care? And an example listed was maybe a physician virtually bringing in dietary or a medical social worker in telehealth visits, and what might the technology support look like? And also, where is the billing coding stand?
Yeah, good question. That's a wonderful question. Very insightful. I would say, like anything else, we're feeling our way through that one. Technically, as you and I are now demonstrating, more than one person can be on a Zoom call. So, and all platforms have that capability. So I can get on the phone with a patient, bring in their mother-in-law, bring in my dietitian, my interpreter. All these things can be done. It does require effort, maybe more effort than it does in the office. And those things have to be weighed. But I think we're getting to the point where we will have it be more or less seamless. As you probably have all witnessed with your own mobile device, it's pretty easy to do a 3 or 4-way FaceTime call or Skype call these days. So we're getting better at that. In terms of the billing, it's really no different than in person, or if you're again tending to the patient. At least during the public health emergencies, all of your E&M codes will work for telehealth with a modifier.
Thank you. A question about how do you envision telehealth across state lines? Do you see the government maybe stepping in to create some federal regulation in the near future, which may take precedence over state control and maybe the state's ability to dictate telehealth scope of practice?
Yeah, another really insightful question. I wish I could be more optimistic. Licensure is controlled by state medical boards. They're furiously and famously guarding of their local physician population with the notion that it's because of quality. And of course there is some, but also that it's a bit of trade protectionism. The best I think we can hope for is regional compacts. We hope, for instance, that in New England and New York, we'll have one where you can freely provide care across state lines for certain regions. I think that's probably the most rosy prediction I can make, but it's going to be a long slog for sure.
Thanks. Telehealth would be a great service for individuals with lower social economic status. What is telehealth doing to provide services to these individuals instead of maybe becoming a luxury item for clinic and individuals who can afford it?
Yeah, really good. You have a really thoughtful audience, Brian. These are great questions. So like so many other aspects of the experience with COVID, the use of telehealth in COVID laid bare some disparities, no question about it. And I alluded to this when I said, as we were thinking about it beforehand as proof of concept or experiments, when you design a trial, you can have exclusion criteria. So you can say, we're going to enroll people in this trial, but if you don't have a smartphone or broadband, you don't qualify. When you get to execution, that's not fair, right? And so we have found out that we indeed have a population of individuals, often minority, often underserved, that can't access. And right now, the best solution for that is telephone audio only visits. And you can do a lot by audio only. We didn't talk a lot about that, but right now they're being reimbursed. Sadly, payers are threatening to not reimburse them. We at ATA are trying very hard to lobby everyone we can that this is our only, until we get an infrastructure project that, for instance, gives us universal broadband, audio only is our only hope. So we're trying very hard to get that cemented into our future.
Great, thank you. Got about 5 minutes left, so we'll get as many of the questions as we can in. Is home testing at the cost of the patient, doctor, or would insurance cover the costs? Is a telehealth visit more expensive than going physically to see the doctor?
So right now, telehealth is paid at parity and it's covered at parity. So I think even for the PHE, there probably are no copays, so it's cheaper. I don't know what will happen after the PHE, but I think probably you'll have no more than your usual copay. In terms of the lab testing, it's an emerging area, and I'm sure during this emerging time you're going to see both tests that are consumables that are paid out of pocket and ones that are covered by insurance.
Great, thank you. This one, these next two kind of go hand in hand. There's a question about, as you talk about doctors utilizing telehealth, is this being used for other providers? And the next one kind of piggybacks. It says, do you see physical therapists maybe coordinating their hands-on abilities with physicians to do a combination of virtual with face-to-face visits?
Yeah, great question. So I didn't have a time to talk a lot about ancillary providers, but indeed, there's a lot of interest, particularly in physical therapy. And there are a number of companies that are doing very well in the remote PT management. One of them is called Sword Health. One was just acquired, and I'm blanking. Ficera was just acquired by another company. So remote PT is enjoying a resurgence. Particularly in the context of orthopedics.
Great, thank you. Someone asked, could you please repeat, there was 2 free HIPAA compliant platforms. One mentioned was Doximity, and this individual was wondering if you could mention what that other one was.
Yeah, it's Doxy, and like so many modern companies that are like, instead of putting .com, they put .something else. This is Doxy.me.
Thank you. One observation that rural dwellers may have some broadband issues. Not really a question, I think just an observation.
Yeah. As I said, we know that broadband is until we get, and hopefully President Biden will be successful with an infrastructure project, and hopefully it will include more broadband infrastructure. It's desperately needed, not just in urban areas, but certainly, I mean, in Wyoming, 3/4 of the state doesn't have even good cellular coverage. So
Excellent.
very important.
Well, I think we made it through all of the questions, and that works well in the interest of time.
Yeah. Well,
Wrap
I
up.
appreciate being invited. Again, you guys have my contact info, and thanks for inviting me, and good luck with your telehealth future.
Thank you, and we'd like to thank our audience for attending as well. Keep an eye out for our future Lunch and Learn series. We have, again, these running through April, and we hope that everyone has a very positive and safe remainder of their week. And thank you very much again to Dr. Kvedar for
Take care
today. And thank you for all of you for attending.